for nutrition and beyond. It's my pleasure to introduce our session chairs for today. First, I'd like to introduce Kamala K.C. She serves as the Social Sector Advisor at the British Embassy, Kathmandu, with academic credentials in public health, nutrition, and educational leadership. She brings over 15 years of experience across NGOs, INGOs, UN, and bilateral agencies. Her work focuses on strengthening governance and integrating nutrition, WASH, health, and local infrastructure, acting as a strategic connector across social sectors. And I'd also like to introduce Yamuna Gale. She's a senior research fellow at the Institute for Integrated Development Studies and an expert in food security governance with over 30 years of experience. She holds a PhD from Agriculture and Forestry University, Nepal, and an MSc from Wageningen University in the Netherlands. Please join me in welcoming them. Thank you very much.
I want to be visible. Okay. Very warm welcome, especially to our foreign delegates and also all our Nepali fellow participants, especially the youths. I'm very much delighted as part of this discussion on the Delivering for Nutrition conference as a joint commitment of South Asia people and government. I just would like to put a few words here because you will be listening for presentations later. Both are from India and Bangladesh. Unfortunately, we don't have any presentations on this particular session from Nepal. We have heard a lot about Nepal today morning. I just would like to highlight a few issues here, flag out a few issues where we can really relate with our presentations later from our fellow colleagues from Bangladesh and India, where the evidences are generated. So one is about South Asia as a hub of people with poverty and malnutrition that keep us reminding what we are discussing and what we have people behind in the rural areas, especially in the rural areas of our continent. This is one. The other one is about the Global Hunger Index. When we look from the Global Hunger Index perspectives, we are doing good. Nepal is a little bit doing good compared to India as such, but by population, India is huge. So this is something we have to really keep in mind. Individual nutrition security is important than the country's security. So this is where we have to really discuss on and then also focus on. The third one is about nutrition and food insecurity among the people. In the morning, you heard about Nepal, consumption of milk. Unfortunate thing in Nepal is that our National Demographic Health Survey report of 2022 shows we have 7 provinces, and province 2, Tarai Pradesh, Madhya Pradesh, is the food basket for us. And this is the province where we have lower intake of eggs and milk by women. So this is the disparity we have. So despite of being a food grain area, women are suffering. So that's why individual matters, gender matters, and children matters. This is very important area I would like to little bit flag out. And more importantly, what I would like to say is it might be same in your country. For us, our constitution is very, very progressive. Our constitution says about food security, right to food, and food sovereignty. But whatever we are talking is simply about technicalities of food security. Forget about rights and forget about sovereignty. That's why we have to really bring that political agenda into the forefront at the regional level, not necessarily at the country level. This is the fourth point I would like to share here. And then more importantly, what I can say is that this area, especially Nepal, is very vulnerable. And as we have heard to Purnima in the inauguration session also, last week there were lots of devastations, disasters, calamities. And this is the area we have to really look into the vulnerabilities and the risks associated with. And our experience of COVID here in Nepal During the COVID period, 87% of our households were suffered or affected by food and nutrition security issues. And out of that, majority were agricultural laborers. 52% were agricultural laborers and women-headed households, and especially women-headed households who had education below college level, higher level education. That's why it has lots of issues related with the education, production, consumption, access to resources, and who does what kind of occupations. All these kind of factors are there. That's why we need kind of integrated solutions, and also not necessarily from the country level, but also from the regional level. So on this note, what I would like to say to all our presenters, Kavitaji as my co-host will also invite them one by one later on, and we will really listen to their experience so that we can also build on your experience in our country, and we can also exchange in other platforms later, so that we can build a common agenda for South Asia, so that no one go hunger, no one dies out of the malnutrition. Thank you, and thank you so much.
So thank you so much, Ms. Gale. So this morning you all heard from the Honorable Minister of Health that she says nutrition is not only about health, but also about prosperity, dignity, and inclusion. And to solve that, to impact at scale, we need integrated solution. And this session is all about integrated solution. So let's welcome our presenter. I'd like to start with Arif from IDE Bangladesh to do his presentation. Welcome, Arif.
Good afternoon and warm welcome to everyone. I think after lunch you are a little bit dozy, so no problem. I think the integrated solution we are going to discuss that will be helpful in the nutrition journey. So I'm going to share our experiences, basically how WASH actually contributing to the WASH nutrition outcomes. That's the journey I'm going to describe. So here I'm going to describe about a rural village or countryside, you can imagine, where people have the unimproved sanitation. It means they have a poured latrine where they can see the flies going in and out, always bad smelling is coming, as well as they are not safe. And also I'm going to talk about the people knowledge and about the hand washing, as well as food hygiene, how these are important when we are bringing, there is two approach we're calling. One is community-led solution, another is the market system. So how market system, private sector can contribute here in the WASH to solve this solution. So I'm going to share my experience here. So basically the experience we gather from one of the projects called Transforming Life Through Nutrition. This is a nutrition sensitive project, the consortium-based project where Helen Keller International, IDE, and Vitamin Angel working together. And our aim of this project is to improve the maternal and maternal health, child health, through the proven nutrition intervention. So here I want to just show this frame that WASH and nutrition have an interlink. When WASH system is weak, then the best diet cannot translate into better nutritional outcomes. And also this is the background of our sanitation progress. In the liberation, like 1971, before liberation, 99% people was doing the open defecations. So in 2015, when the MDG happened, that time 99% people was open defecation free. So before that, basically, the community-led total sanitation, that approach was highly engaged, and also government, our DPH, Department of Public Health Engineering, UNICEF, they combinedly work. But after that, we have another target that is called the SDG 2030, where we have to actually look for the improved sanitation, hygienic sanitations. So after actually from that time, like 2015 to onward, ID start the market system approach with the support of DPHE and UNICEF, so sanitation marketing. So far recent, we have seen the MICS report 2020-25. So far, 73% improved latrine exist in the countrywide. So it is like we're progressing from the open defecation to fixed point defecation. Now we are in the journey of improved sanitations. So here I'm just try to show how these two interventions are integrated. Like CAT's approach actually focusing more on the community motivations, community pressure. On the other side, the private sector approach actually bringing, creating the demand, engaging the private sector, as well as the improve all the solution, affordable, qualityful solutions, so that the motivated women or motivated people can easily access those solutions in an affordable price. That actually this two approach blended here. So actually we implementing this approach in 8 districts of Bangladesh, and these are the 8 districts that stunting rate is very high in these 8 districts. And also our target is basically pregnant women and children who are actually suffer a lot due to the wash. So this is the full approach, because this is also the step-by-step actually we need to work in the CATS approach. Like in the CATS approach, people first actually create the rapport with the community, try to know, understand their problem, then sit with the community to draw all the gaps, like the water, sanitation, hygiene gaps. Then they make a community-based organization, and they make the action plan. So once the action plan is done, then they start the session. But session, if they do, they can do only the motivations. That time, private sector come up with their solution, their discount, their incentive, and also flexible repayment. In the last part, you can see the private sector products coming. So that's actually bringing the solution very easily to community, and also community can easily transform their life from unimproved to improved sanitation part. So blending these two approach, basically we have work in a community like 5 to 6 months. So in the 5 to 6 months, we have observed like the changes. Like we have worked with 120 communities. Each communities have at least 100 household, and in total, in the 1 year, we have worked with 12,711 household. So what we have seen, you see the open defecation is 0, and also the unimproved sanitation also 0. Limited also, these are the indicator I'm showing actually based on the WHO and the UNICEF joint monitoring protocol, the sanitation ladder indicators, and wash ladder and the hygiene ladder protocol indicators I'm showing. So based on working is these two approach, it is like easily the basic sanitation, you can see the earlier it was 18%, now 52%. But our goal is to go to the safely managed sanitation as we're looking for the SDG 2030. So I think here governments and NGO and also private sector, they need to work together. And also hygiene side. In the hygiene side, we also engage here private sector, because the hand washing devices is another important, because only the message is not the one solution to bring practices. So our private sector also sell the hygiene products, sanitation products, and for food hygiene, that is also important what we do in this approach also. So here I can share, like you see, the number of people actually change their even the unimproved latrine to improved latrine. It is like the 40% people have changed. And this change means they have purchased the latrine from the private sector. So there is also the investment from the community side. When community invests the money, it means they have the ownership, they have the practice in future, what actually leading them for less waterborne diseases in future. And also as a facilitator part, basically government as well as private sector, the community leaders, they all are actually work together to solve this problem. So this is also like how enterprise has changed from the earlier to now. Earlier, there was no product diversity, but now they have the more customer-centric, they have the program like they have the demonstration, different type of sanitation products so that customer can buy based on their affordability and also their aspirations, what private sector also doing for the demand creation. So these are the earlier time, the sanitation condition was, once they purchase the latrine, their status is like this. So basically the impact, as we have passed 1 year from the project side, if you ask me what is the direct impact on the diseases part, I will say that still we're working. We have do the more research on that, how actually disease, how much actually reducing. But we can say that how the adoption of product, improved product, uses of product actually increase. We have that solid number. And also we can say that the pregnant women and children living in a community, maybe she has the improved latrine, but side household, she don't have the improved latrine or hygiene practices. The pregnant women have the chances for the diseases, Waterford diseases. So this approach actually help us to do that. We have done also FGD and KII. So one of the household, just feedback here, we brought here, the one household was saying that her children was actually in a stomach pain earlier, but now after having an improved latrine and also hygiene practices, what they are continuing, it is not happening. And also his weight also gaining. And also we have learned from the also government part, the two approach we have integrated here, how it is effective. They said when these two approach is integrated, it is more effective, because they are saying that when only CATS approach working, that time it takes more time, like even 1 year. When private sector and community both working together, it's faster the changes. So this is we have seen. And finally, I want to say that through the private sector, the technology we want to transfer to the community, it makes the people life safe, it makes people life easier and also affordable, which we need to continue through the partnership with the private sector, government, and also NGO in future. So I want to say thanks to our Transforming Life team, as well as our senior management team, CATS community, as well as the government, and our Asia country support manager, Indu. Because of all of your effort, this is possible. Thank you.
Thank you, Arif, for a wonderful presentation. Here I could see clear difference in Nepal's approach and Bangladesh's approach, because you all know Nepal was declared ODF back in 2019, where as a part of CLTS, government gave some incentive to buy those PAN, but here I really like the approach that you engaged with private sector on the access to PAN. So with this, I'd like to invite Gulsen Ara, ICDDRRB, for her presentation. It's all about effect of egg consumption and how they combine that with the psychological stimulation. Welcome, Ara.
Very good afternoon, and thank you for attending this session. So next few minutes, I will talk about the effect of egg consumption and psychosocial stimulation on cognitive outcomes of young children in resource poor settings in Bangladesh. So why early childhood development is so important? From birth to first 3 years of life is very critical for children's growth, because these times 80% of the brain development occurs. And in low and middle income countries, evidence showed that 43% of the children do not reach to their full potential because of the growth impairment, cognitive impairment. And evidence also showed that 165 million stunted children are at risk of cognitive impairment. And early childhood development delays not only affect individual level, it also affect the national productivity. So in Bangladesh, early childhood developmental delays is started from 18 months. So when there is a question about food insecurity and purchasing power, so from children rights, animal food is the first food that drop because of the because of the cost. So animal source protein, protein is also rich in iron, zinc, vitamin B12, and choline, and it is more bioavailable. And egg trials in Ecuador showed that early egg supplementation have high potential for promoting growth. And it also proven that responsive caregiving boosts not only cognitive, also language and support and socio-emotional skills. We conducted a study in urban slum of Dhaka where we combined psychosocial stimulation with IYCF counseling, and we found that it's statistically significantly improved the feeding practices and also socio-emotional skills, but not translated into growth. And we conducted another study in rural Bangladesh where we found that egg and milk-based recipe, which was promoted for one year, we found that the children significantly gained linear growth as well as cognitive and language scores. So the objective of the study is to assess an integrated intervention designed to improve growth, development, complementary feeding, wash practices among children 6 to 23 months. And today I will focus on only the developmental outcomes. So the study was conducted in the northern part of Bangladesh, a district called Netrokona, which is historically poor and poverty poor and climate vulnerable. And it was a community-based randomized control trial with 3 arms, 2 arms intervention and 1 arm is control. And a total of 209 diets were included in each arms, and the interventions were lasted for 12 months. This figure shows how we randomized and allocated the study subjects. So in IFPRI Upazila, that is the sub-districts of Netrokona districts, there were total 63 unions and or wards. Wards served as a cluster. These 63 wards were randomly allocated into three groups, each group containing 10 wards. So the first group is intervention A. This group received egg, psychosocial stimulation, micronutrient powder, wash messages, and standard IVCF messages. And group B received also same kind of intervention, but ECD was not there. And the control group received only nutrition education. So after taking consent, we collected the baseline information, and every 3 months we collected growth and dietary data, and after the end line we collected both dietary and cognitive assessment. So this is the 5 domains that we collected: motor, language, cognitive, socio-emotional, and adaptive behavior. We used Bailey 4 and Wakis behavior rating scale. And here is, I'm just showing the cognitive part, that the ECD component, that the nutrition worker was responsible not only for counseling on the its infant and young child feeding, they also counseled the mother about the childhood stimulation. And we distributed them a bundle of nutrition, bundle of ECD intervention package, like different types of storybooks, pegboard, ball, toys, wooden cart, many things. And also during the session, they also involved the other family members, and they focused on emotion and bonding, communication and language, play and exploration, and daily routines to maintain. Now the results. So in the baseline characteristics, you can find that the 3 groups are quite well balanced. We didn't find significant difference in different indicators. And this table shows the baseline characteristics of mother and children. We only found that in the intervention A group, mother had higher education, and they have more obesity and obese compared to the other groups. So these 2 graphs shows the length gain over time. So the first graph, you can see that the baseline, the mean length was 68.1, which was pretty similar in all groups, and we didn't find any significant difference up to second follow-up. And in the third follow-up, that was measured in 9 months, we found borderline significance. And after the intervention, we found that the intervention A group gained significant weight and length, and intervention B as well compared to the control. And in the second graph, you can see the weight gain over the time. Although intervention B group maintained pretty steady weight gain, but however, it was not significant. And this is the baseline measurement of cognitive, emotional, language, motor, vocalization, and approach score. And we didn't find any significant difference during the baseline measurement. And after getting the intervention, we have found that in terms of cognitive standard score, the intervention A group scored significantly higher compared to B, even C. So there is also significant difference between B and C. And in terms of language standard score, again we found that intervention A group scored significantly higher compared to C, and B and C is the changes was not very significant. So we can see that the cognitive development that we found in both A and B could be the effect of egg supplementation, and for language that we only found in intervention A might be effect of ECD. So these are the other domains, that is motor, vocalization, and other approach, and we didn't find any significant difference in the 3 groups. So when we applied linear regression and we adjusted for all variables, and we again found that intervention A group had 7 score higher cognitive score compared to the control, and intervention group had around 3 score higher cognitive score compared to the control. And for language, again we found that intervention A had around 4 times higher language score compared to the control. However, we didn't see any significant difference in group B, who didn't receive any ECD intervention. So in conclusion, we see that both intervention improved growth and cognitive and language development, and intervention A had a higher, strongest overall impact, and control group showed lowest score in terms of ECD. So this is an innovative study in Bangladesh, because we have implemented this study using community platform and government infrastructure we used, and we also used the community people. They voluntarily involved with the egg distribution. So we can see that this is a huge potential for scale up. So we would like to advocate our government agency who deals with infant and young child feeding and also child development. They can use our model for scale up, and also other stakeholders who work with this field. Thank you for your patience hearing.
Thank you, Ara, for a really interesting presentation. I think this is kind of low-cost intervention, as she suggested, we should also try and test in other countries. So after doing 2 excellent presentations from Bangladesh, let's now move to the India. So we have Hedvi Saha from Center for Health, Education, Training, and Nutrition Awareness. Welcome, Hedvi.
Good afternoon, everyone. It is a great pleasure to be here at Delivering for Nutrition 2025. My name is Hetvi, and I am present Chetna, a 40-year-old organization working on health and nutrition for women, children, and adolescents. We are based in Gujarat, Ahmedabad. Today, my presentation is on Empowering Adolescents for Better Health, a multi-component program in Ahmedabad's urban slum, India. This presentation highlights how a community-based integrated program work with adolescents, families, and frontline workers to improve nutrition and health outcomes in the urban slum community. Before talking about the program, let's understand the scale of the challenge. India has 253 million adolescents. Around 31% boys and 59% girls are anemic, and only 78% girls follow safe menstrual hygiene practice. The situation in Gujarat, where the program was implemented, only 69% adolescent girls and 36% boys are anemic. Around 66% girls follow safe menstrual hygiene practices. So, our goal was nurturing young leaders, strengthening health, and empowering future. The objective was enhance knowledge on health and nutrition among adolescent girls. And the second one is build the life skill. We believe that knowledge alone is not enough. Adolescent needs practical life skills to navigate social pressures, make informed decisions about their health, and become the change agent in their own community. The program was implemented in 5 urban slums of Ahmedabad city, Gujarat. The intervention period was December 21 to December 23, and we directly reached around 1,748 adolescents. So, the core approaches are, firstly, it was adolescent centered. Every activities was designed to fit the real situation of urban slums. We combined health education with life skill education and developed the content according to their age and gender. We actively involved family, so the parents and caregivers are key influencer, engage them through group sessions, home visit, and mass awareness activity. And we work closely with frontline workers to build a system that could continue even after the project was ended. So the key strategies and activities are, we started with the mapping of the community and knowledge attitude practice survey of the adolescent through a mobile application to design the need-based intervention, strengthening health knowledge through home visits, group sessions, interactive IEC materials, and mass awareness activities such as a street play and drama. In improving food habits through the diet recipe demonstration, we shared low-cost iron-rich recipes like pulses pulao, mixed vegetable paratha, dates laddu, and encourage them to add iron-rich food in their daily diet. We also held a regular health checkup where the HB was measured through digital HB machine, and we tracked their HB and BMI over the time to see the progress, and anemic adolescents were received the IFA tablet. A key part of the project was fostering adolescents' leadership within their community. We identify and trained the youth champion, adolescents who could read and write, had a good communication skill, and willing to work in this field. Life skill training sessions were conducted at the field level in the afternoon batch on weekends, so all youth champion can come. The sessions were highly participatory, using stories and games, interactive activities. Through this, adolescents learn essential life skills such as decision making, communication, negotiation, and critical and creative thinking. Youth champion led peer education sessions, awareness events, small group discussions supported by health education kit and field staff. Their efforts were recognized through social media stories, peer groups, acknowledgement in the peer groups, mass awareness activities, and the token of appreciation like providing nutrition kit. This peer-to-peer approach proved highly effective because when adolescents see their peers leading change, the message becomes more relatable and inspiring. We also strengthen the frontline workers through build their capacity on adolescent health and well-being. This slide shows the key result. Nutrition and health knowledge increased from 10 to 70%. Prevalence of anemia reduced by 16%. Overall nutrition status improved 62 to 73%. and the menstrual hygiene practice improved from 65 to 91%. These slides show the clear improvement in the nutrition status of adolescent. 63% normal BMI increased from 63% to 72%, and overall 80% adolescents showed increase in their BMI value. These changes happened because individual food intake can improve quickly, but moving from thin to normal nutrition takes longer time, and it depends on household decision, food habits, food security, and daily dietary practices. Anemia reduced from 84% to 68%. The knowledge was increased from, the knowledge on balanced diet is increased from 13% to 67%. Knowledge about how to prevent anemia is jumped from 1% to 78%. 91% girls follow the safe menstrual hygiene practice. We track all of this information through mobile application, which also recorded our regular home visits. Behind every statistic are real stories of change, like Renu combined knowledge about menstruation with life skill, gaining confidence to speak in front of 150 students. Rohan learned why he was weak and developed resilience to stick with IFA and diet changes. This side, there are the comics which are developed by youth champions, and that are the real stories of the youth champions. So, knowledge alone informs, life skills alone build confidence, but together they empower adolescents to become unstoppable agent of their change. So we learned peer-led model works. Adolescents listen to their peer. Life skills are essential because information alone doesn't change the habit. 2 years is just a beginning. Real change needs long-term support, follow-up, and continuity. Silos don't work. Health, education, and community sector must align. Families and communities matter because we can't change the adolescent without changing their families and communities. Monitoring always motivates. Seeing their own progress builds ownership. So my recommendation are integration of life skill into school curriculum, training, and every interaction. Gender-sensitive program engaging families and communities to shift mindset from cure to prevention. Universal access through government schemes across all schools. Health, education, and social sectors need to work together. Continuous tracking, monitoring, and evaluation, and creating data, particularly adolescent age group. So my conclusion is adolescent health is not just a health program, it is a development investment. When we build adolescents' knowledge, life skill, and well-being, we reduce inequality, strengthen community, and create opportunity for the next generation. Thank you, Delivering for Nutrition Conference funders and our funders, Azim Premji Foundation. I also want to thank our incredible field team. They are the real heroes. Without their dedication, none of this would be possible. Thank you.
Thank you, Hedvi, for a really interesting presentation, and thank you for including adolescents in your intervention. You know, when it comes to nutrition, adolescents are mostly neglected. And when she was talking about menstrual health and hygiene, MHM, I was thinking, like, in Nepal, there are a lot of food taboos associated with menstruation, which directly impact the nutrition of adolescents. So with this interesting presentation, now I'd like to move to Pakistan. So we have Sidra Bashir from Center for Economic Research in Pakistan. So Sidra, are you here? Okay, welcome. Floor is yours.
Okay. Hi, everybody. Good afternoon. It's an honor to be here at Delivering for Nutrition Conference in beautiful Nepal. My name is Sidra Bashir, and I'm representing GIZ Pakistan. I'm joined today by my colleague Faiza Wahab, sitting in the audience, which is the lead implementation agency for our project. Today, I want to share an important story about improving nutritional outcomes for adolescent girls, often an overlooked issue. Let's take a moment to visualize a troubling reality. Imagine over 50%, okay, clicker not working. Imagine over 50% of the adolescent girls experiencing fatigue, weakness, and looking pale. Unfortunately, this is the daily life for many girls in Pakistan suffering from anemia. Sorry? It was working before. No, I just need to move this. No, this one. Okay. Sorry, I'll just restart a bit so that you can get some context. So, let's take a moment to visualize a troubling reality. Imagine over 50% of adolescent girls experiencing fatigue, weakness, and looking pale. Unfortunately, this is the daily life for many girls in Pakistan suffering from anemia. Shockingly, only 18% of these girls have access to adequately diverse diets, and merely 30% of the households consume fortified flour, which is an important for achieving nutritional diversity. This stark reality highlights the urgent need to enhance nutritional outcomes for adolescent girls through an integrated approach. Our approach is built on a high leverage strategy where we are integrating nutrition interventions directly into the government's largest social safety net, the Benazir Income Support Program. The mission is very clear, where we are leveraging this existing infrastructure of social protection program, specifically the Talimi Wazaif Social Protection Conditional Cash Transfer Program, which is basically ensures conditional cash transfer based on attendance of the girls in school. So we're trying to improve adolescent girls' nutrition through these multiple pathways. Ultimately, the objective is to strengthen the state's capacity in order to implement highly effective multi-sectoral social protection programs that can significantly reduce anemia nationwide. The immediate aim of the project is to pioneer a truly multi-sectoral model. This means testing the joint multi-sectoral functional engagement of 4 critical actors: the health, education, social protection, and food departments at the provincial and federal levels to deliver a context-specific unified approach. This is something that we have also been hearing since morning about, an integrated approach and involving multiple departments. And this is exactly the perfect example of those models where multiple sectors are engaged. To deliver on our multi-sectoral mandate, SOPRAN, which is the name for it, is leveraging social protection programs for adolescent girls' nutrition. The acronym that we use is SOPRAN. To deliver our multi-sectoral mandate, we adopted a holistic package across 3 critical pillars. Number 1, which is supply. Number 2, driving demand. And number 3, strengthening the enabling environment. As part of driving demand for better nutrition, we started off with WIFA supplementation, which is the iron folic acid supplementation provided, combined with very high quality, locally and culturally curated nutrition education sessions to a comprehensive social and behavior change communication strategy. We specifically invested in the capacity building of teachers and lady health workers to deliver these vital sessions effectively both at school and within the community. As part of the second pillar of our interventions, which is strengthening supply, we focused on improving the local availability of fortified foods We work directly to strengthen local small-scale flour processors by installing microfeeders, providing premix, and building their capacity to produce high-quality fortified flour. Additionally, we also provided cash vouchers to all beneficiaries, linking them directly to fortified flour access. The third pillar of our intervention was enabling environment, which required us to work at the policy level, and therefore we focused on building the capacity of key government stakeholders from the food department and the food authorities, training them specifically on fortification processes, quality assurance, and their essential regulatory roles to ensure the long-term sustainability and safety of fortified products. Through this multi-sectoral approach, we are enabling the environment for the girls to act as change agents. Our monitoring, learning, and evaluation framework is built to test the fundamental hypothesis of this project and ensure course correction along the program implementation. We firstly assess the change in knowledge, attitudes, and practices among adolescent girls. This happens after the comprehensive rollout of social and behavior change strategy and delivery of nutrition education as a technical skill. We are also rigorously evaluating the improvement in awareness and nutritional intake of fortified flour following the capacity strengthening of local mills and distribution of cash vouchers to beneficiaries' families. Most innovatively, we are working on testing the potential of adolescent girls to act as catalysts for change. Both beneficiaries and non-beneficiaries of the social protection program are named as Talimi Wazaif by promoting healthier nutrition practices among their peers, families, and broader communities. The learning framework is designed to capture this ripple effect as well as generate evidence for the policymakers. This entire project implementation is guided by an iterative theory of change. This is not we did not develop a static document, but rather it was developed and refined through continuous partner meetings and workshops. This adaptive learning loop is what allowed us to be agile, adjusting our strategy in real time based on early feedback and implementation barriers. To measure impact, we utilize a before and after study design, which enables the MLE team to assess changes in nutrition knowledge, attitudes, and practices among adolescent girls and other stakeholders. Initially, we conducted a baseline. After the intervention, in the middle of the intervention, we conducted a midline, and now we are in the process of conducting an endline currently, for which the results will be available in February 2026. The mixed methods approach that we used for this offered us methodological flexibility, which enabled us to address questions with sufficient depth as well as breadth. Quantitatively, we collected extensive baseline data from 567 adolescent girls across the 7 highly diverse districts of Pakistan. Qualitatively, we gathered essential insights through focus group discussions and key informant interviews with a wide range of stakeholders, including parents, teachers, health workers, religious leaders, district officials, and flour mill owners to ensure that we capture the holistic content of change. The qualitative component allowed us to examine factors influencing nutrition behaviors and attitudes of adolescent girls and explore attitudes of family and community members. Additionally, the findings have been triangulated and will be triangulated at the end as well with National Nutrition Survey of Pakistan 2018. We'll move on to the baseline findings now to showcase as to what did we learn at the time of baseline. At the time of baseline, we learned that there was, among the girls that we interviewed and we conducted focus group discussions with and talked to all these stakeholders, we learned that all the stakeholders, specifically the adolescent girls, they had low understanding of core nutrition concepts, which impacted their dietary choices as well. So for example, the adolescent girls exhibited very inadequate nutrition diets, which meant that they consumed food from only 5 out of 9 possible food groups within a 24-hour time period. This nutritional inadequacy is further complicated by limited weekly consumption of key food groups, which is fruits, vegetables, meat, and dairy. There were inconsistent practical habits observed among, meal consistency, snacking as well, where breakfast is the most regularly consumed meal. However, lunch is usually skipped by the adolescent girls, with only 22% girls reporting that they do not miss a meal within a typical week. Time constraints and low appetite are some common reasons that they share for skipping, while dinner is often skipped due to unavailability or preferred foods. Snacking is not a daily habit for most adolescent girls, and when it occurs, they usually eat like biscuits and chips over healthier options. There is another contributing factor to this entire nutritional status and dietary habits, and that is the school food environment.
Sidra, can you
which
go to the final slide? Your time is already up, sorry.
Okay, sorry. Further limit the options, and there are certain constraints like financial constraints, taste preferences, and accessibility issues, which are primary barriers limiting nutritious food consumption. You might be able to see that the awareness lies low, but there were some systemic barriers identified, which we do not need to go in detail. However, we saw progress at midline, where we saw significant improvement in the indicators at the time of midline. And we also have a very interesting quotation where the girls themselves had, absorbed the information that they were being given through nutrition education sessions. At the time of adaptive implementation, I've already talked about this, that how we have adapted to this particular approach. And in terms of way forward, I do need just 30 seconds to share the way forward as we aim to develop a scalable and sustainable approach where we are using the scale in, scale out, and scale deep approach, where we want to institutionalize the model with the government. We want to expand it across the districts and the provinces, and we want to dig deeper by embedding behavior change and create a lasting impact and sustainable cultural beliefs. There were some operational pathways to scale, which we have recommended. However, at the time of endline, we will showcase more recommendations, which will be holistically for the follow-up phase of this entire program. These are some of the pictures, and very thankful to all the project stakeholders, specifically GIZ, Gates Foundation, Benazir Income Support Program, which is a social protection program, Nutrition International, World Food Program, and SERP. Thank you very much.
Thank you. I think adaptive programming is what we need in this changing context, because context is changing so quickly, and what we need is adaptive management. So with this, now we are moving into our final presentation, which is virtual one. So we have Sudipta Mandal from Project Concern International. So his presentation will focus on leveraging women collectives for improved child nutrition. And I think he is from India. Over to you, Sudipta.
So we're just going to pull up the presentation. We'll check that he's online, and we'll put it up on the screen. Just give us a moment, please. Thank you very much.
Oh, nice. So we are about to projecting your presentation, Sudipta. Or you can start in between by introducing yourself.
Yeah, that's right. First of all, apologies for not making it in person to Kathmandu, which is a beautiful city. But nevertheless, I am really grateful to IFPRI that they have allowed me to make this presentation in virtual mode. So, what I will present today, actually, I am evident from a longitudinal study conducted in Bihar, which explores how women's collectives can contribute to strengthening child nutrition outcomes. This work was carried out in partnership with Jivika. Many of you in the audience might be knowing Jivika is the state rural livelihood mission. They run and manage the large network of self-help group women collectives in Bihar. Can we move to the next slide, please? So let me start with the context, because as all of you know, we actually use novel platforms to promote health promotion, mainly health and nutrition and wash. So we work very closely with Jivika, we provide them technical assistance. Jivika uses multiple strategies to improve the nutrition of women and children. And we ran this program for years, and there are independent evaluations that have confirmed some positive changes. But in this case, today I am presenting a small pilot, and in that pilot, we are trying to understand whether very intensive programming by the Jivika Paga, that is the community resource person, the CRPs, we call community nutrition resource persons, whether when they are engaged intensively to promote, IYCA practices among, mothers or caregivers who have, 6 months to 18 months old children, whether, things change and improve drastically or not. The next slide, please. So this pilot program, it was started with the, rationale that the intervention was grounded in simple but powerful ideas, because focused parenting on nutrition can significantly improve growth outcomes during the first 1,000 days. We wanted to use that opportunity first 1,000 days, and GBK implemented a model. So this pilot is basically a model targeting children aged 6 to 18 months across 4 districts: Bhagalpur, Jhanabad, Samastipur, and Vaishali. These districts were chosen deliberately because they serve as learning and innovation hubs and have strong program teams capable of supporting new approaches. Next slide, please. I don't see this. Okay. Okay. I've already talked about this slide, so can I move to the next slide, please? So the intervention model has 3 critical components. One is parenting, so teaching mothers how to provide diversified diets, cook appropriately, and monitor growth themselves. And second is the community engagement, mobilizing family members, self-help groups, and health sub-centers. So every self-help group, there is a village organization. This is the upwardly federated structure. In the health sub-center, HSC, they have these are health subcommittees, and also these CNFPs, they are also trying to mobilize the community through not just SHGs, the main platform of IFPRI, but also the local health sub-centers, and the support and track growth regularly. And also they are trying to enable the key stakeholders, training CNRPs to deliver counseling and accurate anthropometric assessments involving ordinary workers and shopkeepers and influencers to create a supportive experiments we were asked to do, because in PCI there are two, different arms, the program team and the research and evaluation team. So they are kind of work independently. So we were asked to do the evaluation of this pilot programming to understand whether the program was effective or efficacious. So we did the evaluation. So with the aim that to assess the effectiveness of this SHG-based behavior change intervention, we looked at 4 areas: improvement in nutritional outcomes, dietary diversity, caregiver knowledge and practices, and their participation in SHG-led nutrition activities. Our hypothesis was that children in intervention, however, would show significant improvements in wasting and underweight compared to the comparison group. This also gave us an opportunity to examine whether dietary diversity directly influences growth outcomes. So we also did some anthropometric measurements to understand whether improved dietary practices and counseling can change the stunting, wasting, and underweight. Next slide. So in terms of methods, so what we did actually, so it was a quasi-experimental design. We used a longitudinal cohort design in which from 4 districts, as I mentioned earlier, we took 1 block for intervention and 1 block for comparison. So the neighboring block we took of the intervention block as comparison block. So we had altogether 4 blocks for the intervention and 4 blocks for comparison. And in all these blocks, we also mapped out all these mothers who have 6-month-old children. So we actually used a take-home approach. When we did this during the baseline, we got hold of 340 such mothers in the intervention arm from those 4 intervention blocks, and we had 253 mothers from comparison arm. And we then followed them up after a year when the 6-month-old children became 18-month-old babies. Then we did the second round of quantitative survey, that's the end line. So in that, there are a lot of lost to follow-up cases. So we eventually had 202 mothers we could track and we could interview them. Those were part of the 340 what we did in the baseline. Similarly, in the comparison arm, we could track down 204 mothers. So for the analysis, what we have done, we only used those mothers who have participated in the survey in baseline and inline. So altogether, we have 202 plus 204, 406 mothers. So our analysis, subsequent analysis result that I am presenting is based on these 406 mothers. Next slide, please. So let me talk about the household characteristics. So that at baseline, so you can see that the baseline, the household characteristics between these 2 arms, we can call them intervention and comparison group, in 2 groups. There are almost similarity in terms of religion, in terms of caste categories, in terms of sources of clean drinking water. We have other variables. We have just completed the survey in November, still doing the analysis. And on the individual characteristics, what we have found that there is a good balance between intervention and comparison groups. So median age of these mothers are, you can see, 24 and 22. Most of them mothers have been to school, so when we say educated, so whether they have been to school, formal education. Husbands, median age, husband education, everything almost there is negligible difference between these 2 groups. So basically indicates that whatever we are doing, the comparison is between equal type of groups. So it's kind of valid comparison. So can we move to the next slide, please? So I present some results. So what we have found, so we asked about knowledge. So when we asked the mothers about the knowledge around diet diversity, whether they knew 4 out of 7 food group they should give to their children every day, then we have seen remarkable progress between baseline and endline in the intervention. who were part of the comparison group. We also asked on different food consumption, food group consumption, and we found significant changes in animal source proteins, and also we found some positive changes in vegetables and other things, other food items. We did not find much in other food items that we have given you. Thereby, we have got the statistically significant results. Finally, we did this anthropometric, and in anthropometric, we tried to understand whether there is a changes between these intervention comparison groups on stunting, wasting, and underweight. We used WHO guidelines for doing this measurement for month specific, because all these children now 18 months old, and we compared that, and what we have found, the intervention may have had some effect on protecting the stunting or the height increase, height reduction, but its impact on other nutritional outcomes like wasting, underweight appears limited or inconclusive, because we didn't find any significant difference. Statistically, these differences are not significant. We try to do it through by controlling some other characteristics. There also the differences were not statistically significant, although there is some, if you see the result shows, at least in case of stunting, some degree of least percentage of children in intervention arm became stunted than the comparison of person. This is not statistically significant. We're still doing some more analysis to see, but our prima facie evidence suggests that there was no statistical significance. That means there was no changes in the anthropometric measures of stunting, wasting, underweight.
Dr. Mando?
Sudipta, requesting you to move to your concluding slide because your time is already up.
Thank you.
Sure. Please go to the next slide. So as I mentioned, that we found no direct immediate association between dietary diversity and anthropometric indicators among children aged 6 to 8 months, although there are strong improvements in dietary quality, nutrition knowledge, and key caregiving practices. Next slide, please. So in conclusion, we can say that although the intervention did not lead to a large anthropometric changes across all indicators, it significantly improved dietary quality, nutrition knowledge, and key caregiving behaviors. So what we can, as a way forward of the implication is that these CNRPs or Jivika Community Nutrition Resource Persons are there, if they are trained well, if they are given the real tools and the mandate, other SRMs in in India, in other states, they can also deliver similar interventions at a low cost. It will be a low cost model which can be taken to scale. But the only thing that there is no guarantee that it will have corresponding changes in the anthropometric measures, which is also in line with other evidence that other literature or existing literature that we have found. There also they do not find such changes. But there is definitely changes in dietary quality, nutrition knowledge, and key caregiving behaviors. Next slide, please.
Thank you, Sudipta, for your
Thank you.
presentation.
Thank you very much.
Thank you. So thank you, everyone. Thank you, all the 5 presenters. Now we just have 20 minutes. So out of that, 15 minutes will be dedicated for question and answer. And I'd like to invite my fellow co-chair to facilitate the Q&A session.
Thank you, Kavitaji. While colleagues are setting the space there, I just would like to bring into your notice that we had divided our role, that we will do the opening, then invitation and question answer, and then closing remarks. 50-50 responsibility, and accept the biological responsibility. Everything can be shared. This is a reminder for the gentleman. We can share every responsibility except the biological responsibility. So, thank you so much. I'm just counting Sudipta also. Thank you, everyone. Now I would like to request our panelists to be in the dais, please, so that everybody can be, you can be visible to the audience. So please, please. One more. Okay. Now, before going to the audience, I just would like to take a few points from the presenters because it's very relatable. As I said before, we didn't have any presentation from Nepal, but it's very relatable. As we see that Bangladesh presentation, first Bangladesh presentation, I could really relate with our situation here also, and also in South Asia, and the peer learnings, we can also really relate. I can give you one example that in the brick kilns, where I had some projects, the peer review really helped them to protect themselves from the bad touch from the master, and then they can carry more loads and then they can earn more, for example. And a small child care center helped the women to earn equal to her husband. So there are very few things, so small things, but we can do lots of changes there. So this is very relatable, and Headpit's presentation I really appreciate on that part also. And from the Pakistan colleagues, the institutionalization part, scaling in, scaling out, scaling deep. This is very important because project comes and goes. Who cares? This is the phenomena we have in Nepal also. This is very important for us to really learn from each other. And finally, Sudipta is learning on the minimum dietary requirement diversity. In Nepal, unfortunate thing is that our minimum dietary diversity situation in Nepal, all the women, only 56% women have access to minimum dietary diversity. And unfortunately, on the out of 7 provinces, the province which is the grain center for Nepal, there women have less access to dairy and egg, for example, and Muslim women have less access to green vegetables. So there are issues at the individual level, at the societal level. So that's why I want to request the audience to put your question very precisely so that we can have more chances to listen from the panelists. So I would like to take first round, then go to the second round. The first row, gentlemen, then the second, and then third, fourth, fifth, and then last, sixth lady. Yeah,
Okay. This is Abjal from Bangladesh, ID Bangladesh. So thanks to all the presenters. So my question to ICTDRB representative. So you are actually studying on the Netrokona. It's a very, I should say, remote area, and actually it's a flat-prone area. So you have given some eggs, milks, etc. actually given very good result. But climate resilient is a very important area. And day by day price also is hiking of the different goods. So if in this case, how you can actually address? So it is very difficult, to available egg, milk, and other diversity of food.
Okay,
so
thank you,
this
sir.
is one. And another thing also, you have actually suggest to the government to implement your model. So I don't know how actually you specifically advise to the government so that they can actually integrate in other upazilas or other district also, how you can actually ensure it. Should I take all the presenter or?
Can we limit to the 2 questions first?
Okay.
And then we may come to the second round if there is
The
a
other
time.
ones had be, so you have actually good findings and you have lot of behavioral change and education, but I don't find any digital approach so much. Yeah, you different issues, but is there any critical reflection by the adolescents, how they get actually the menstrual different products? We know sometimes it is very difficult to get, so there is a supply chain problem. So how they get it easily? Sometimes it is very difficult at
Thank
the
you,
field
sir.
level.
Let's
Thank you very
limit
much.
there. The second person, yes, on the third row, yes.
Thank you. My question is to Ariful, I think, from IDS. So I have only one question, not more than one. So my question is directly, as Yamuna ma'am also said, that I'm from Nepal. So your presentation is very much relevant to Nepal context as well. So my question to you is, like in your presentation, it's already, I think it's a well-established statement and well-established concept that multisectoral connection contribute to nutrition security, and in your context, like multisectoral connection is also contributing to your project. So it's I think it's well established. But my question is, if you have any means tangible or measurable observation or database findings, like what change you observed, no? So it would be more learning to us. So this is my question
Thank you,
to
sir.
you. Thank you.
Thank you, sir. The third person on the पछाडि हजुर उहाँलाई short
Namaste. Thank you. Thank you for the insightful presentation. I'm Rajendra Maharjan, country coordinator for ITO right now, and we are working on institutionalization of SRHR education in Nepal. So, given that adolescent malnutrition, especially among girls, especially among girls, closely linked to the child marriage, MHM that recently shared, unintended pregnancies, limited bodily autonomy, and all these challenges. I believe that the SRHR and CAC integrations with the nutrition education is quite important. So anyone of you have any experience of integrating CAC or comprehensive sexuality educations in nutrition program? And the second question would be, how can we ensure that such kind of integration, SRHR, climate, nutrition, WASH, such integration is youth-centered and addresses the unique needs of young people with disability and young people from LGBTIQ community people. Thank you.
Okay, thank you. Then yes, and then after to her. Yeah.
So my question is to Hetbi for Ahmedabad intervention. So thank you very much for delivering the wonderful presentation. And it was very interesting for me that the reduction in anemia prevalence was very impressive. I'm curious to know that what was the timeline for baseline and endline. And additionally, if you could provide a little information about this intervention was only led by your organization, or also supported or led by the government as well.
Very good. Thank you, sir. Then next, yes.
Laurie Miller from Tufts Friedman School. Thanks everybody for a really interesting afternoon. I'm going back to eggs and would like to just ask some simple methodological questions. First of all, was the person or the people who did the Bailey testing, were they blinded as to the experimental group that the child was in? Secondly, were you able to control in any way for the contact time with the research team, because it sounds like Group A got a lot of contact time and maybe the Group B didn't get nearly as much. And thirdly, I really hope the answer to this is yes. I hope you have some plans for follow-up, because this would be a fascinating group to see what happens 6 months, 12 months, 5 years from now, given this input in early life. I agree with the questions of affordability and sustainability. And given that you've done such a good job with this study design now, I think it's essential to follow up what happens in the future to this cohort of children. Thanks.
Okay, thank you so much. The very first. This is the last one.
Thank you. I'm Dr. Afsana from Helen Klein International, Bangladesh. Two questions. One for Mr. Ariful, that in the transforming lives through nutrition, there is 8 outcomes we know. There is specific and 3 is nutrition sensitive. So when you will go for the inline study, so is there any indicator you have said to see only the impact of WASH on the nutritional status outcome? That is to you and to Sedvi, I think. So your all results are on the knowledge, and you have shown that there is change in the anemia, there is change in the BMI. So is there any other intervention you have included in your project to see the attitude practice? Because accessibility, affordability, everything is actually needs to address when we want to see the changes. So only knowledge, I think, is not enough. So is there any other additional intervention is there? Thank you.
Thank you so much. Now we have 5 minutes. So I would like to request all the panelists for 1 minute and 1 minute for Kavitaji to close. Yeah.
Thank you. Maybe I'm going fast. So about the transferable result, as I said, that private sector also engage here. For private sector, it is like all the gaps are like a niche market. So I even mentioned like 40% latrine sold. So household have the improved latrine, and also private sector have the income also. So there is, but I also mentioned that for the disease, how much actually reduced, we need to do a scientific study. That's we'll do. But in terms of the physical like result, the latrine, everybody have the latrine, improved latrine. That's very clearly there. And about our transforming life, the indicator, basically I mentioned, we actually took here the indicator from WHO and UNICEF GMP ladder indicator, where actually indicating in the sanitation, there are 5 indicators: how much open defecation, how much unimproved, how much limited, how much basic, and how much safely managed. There is a like upwarding, these are the indicator, and also some for the hygiene also some indicator have. So this is like if these indicators are achieved, definitely there will be also impact on the health. So I think we'll do that very soon. Then we can say that there is a highly linked with the health indicators.
Thank you for the important questions. First, when I was selecting the study area as Netrokona, and we did a study like how many egg farmers there. So there are many households, they are involved in egg farming, and we also face some flash flood problem, but still our intervention didn't affect. As Bangladesh government are investing a huge amount of budget for social safety net program, and early childhood development is very important because it's really work for future potential of the children. So I think this is investment really needs, and government, I have already shared my findings, and few of them already showed interest that they can think about it and they can pilot it in some vulnerable areas, then they will think about the scaling up. And for the methodological issue, first of all, we have a separate team, intervention team, implementation team, and evaluation team. And for the tester, we recruited during the baseline when the intervention was not started. And after finishing the baseline, they were not in the field, and they didn't know anything about the group allocation. And after the intervention, we again recruited them, and again they tested the children, and they were totally blind because they didn't know. Only as it is a community-based trial, so we tried, although we tried that the evaluator, especially who measured the compliance and also the anthropometric measurements, we tried, but still somehow they knew about that, because when we asked about the egg consumption, they understand. Even sometimes the babies are so used to that, the mothers told that don't utter egg, then they will bring the egg. So better use some sign language so that we can answer your questions. So the children became so used to that they will have an egg every morning.
Okay, so I will start from the last question. So our second intervention is on life skill. We believe that knowledge alone will not work. So once we give information about the nutrition, but when we give about information about the life skill, so adolescent boy and girl can decide what is the good and what is the bad for her or his. So definitely with nutrition we focus on life skill to change their attitude and practice. Second one was about the baseline and headline period. So the intervention period was total 2 years, and it was totally implemented by our organization Chetna, and Yes, but we support, collaboration with health department and women and child development to smooth implementation. And the first one is the menstrual hygiene product. So we focus on whatever girls are using, it should be safe and hygienic, either sanitary napkin or it could be cloth. So our focus on that only. Thank you.
No, I think I was not asked any question.
Maybe one question was there on the how do you integrate that nutrition course, the CAC in the nutrition course. Yeah? So if you have experience on that.
Yeah, sure. So actually in Pakistan, like we have 4 provinces and 2 areas which are like federally administered area. So we have like really diversity in the provincial government and their approaches. So in one province which is called Punjab, and that is a big province of Pakistan, and they have already integrated the nutrition education in the curriculum. So we are actually also using that platform to learn interprovincial learning. And also after like this pilot of Sopran, we are like leveraging social protection through adolescent nutrition. For the adolescent nutrition. So through this platform, what we are doing, we are generating the evidences to, as already mentioned in the presentation, we are focusing on the scale up, scale in, and scale deep. So like at the community level, at the policy level, and evidences level. So we are providing evidences to the government of Pakistan so that like they can incorporate it in the education, health, and food departments, because like this is a multi-sectorial approach. So like through social protection, we are integrating the health, education, and food departments, so that like everyone can contribute and they can leverage the interventions.
Thank you so much. Now my co-chair, Kavita ji, please have a closing statement.
Much for all the interesting presentation. Please give a round of applause to all our presenters. I think it's okay. And also thank you so much for all the participants for your interesting and engaging participation. So I'd like to summarize this session with 6 key takeaways. So one is integration is not a slogan, it's a delivery. And thank you for all those who are delivering it. It's really interesting to hear all those things. And second is data system and adaptive learning keep program honest and relevant in this changing context, which I think we all need to practice that adaptive programming. And third is like we need to marry demand with the supply, and thank you for Bangladesh colleague to doing that and showing that examples to us. And fourth, center the adolescents, because youth are the one who we need to focus, and they are the one who are often neglected. So I think we need to focus them on the nutrition intervention. And 5 is the leverage social protection network for nutrition, which is so crucial in terms of scaling and the impact in the nutrition. So with this, I'd like to conclude this session here. Thank you so much once again, and thank you the organizing team for giving us this opportunity. Thank you.
Thank you very much, everyone. The next session is going to be at 4 o'clock in the Bagmati Ballroom. For now, I welcome you all to join for tea, except the presenters and then the session chairs. Please join us for a photo. Thank you very much.